Okay, so good evening, everyone. Good evening, everyone. A very good evening. Here we are trying to discuss the NEET SS previous year questions. So I have compiled 15 odd questions. These questions are from the previous 3 years, 22, 23, and 24 NEET SS, right? So just let's go through each of these questions. As far as NEET SS is concerned, you will face three sort of questions. One sort of question would be the tricky ones that would have some clinical scenario or some guideline related scenario, and you have to actually use your brain cells and link correlate things and then answer. Some would be straight away factual questions, either you know them or you don't. They could be the some genes or some incidence number or some purely factual information that they're trying to test. And the third set of questions would be those questions that would be very, very easy questions, like NEET PG level questions, your MBBS level questions, very basic general pediatrics question that each and every pediatrician should know, right? So dealing with all the three questions would be different. Easy questions, you cannot afford to mark them wrong. Factual questions, these you will get a hold on by solving MCQs again and again so that you know which topics are more frequently asked, which factual questions are actually the examiner's favorite, right? And finally comes the tricky part, the tricky questions. They won't do much in your ranks if you score them very well, very good. But they're mostly based on the recent research, and these just are to test your knowledge, just to check whether you are up to date or not, right? Even if you crack the easy ones and the factual ones, you are going to have a good rank, but these tricky ones will make you a top ranker, right? So let's start with the session discussion. Moving down to the first question, which of the following is true regarding dyslexia in a child? The options we have are that reevaluation of diagnosis is required. Reevaluation of diagnosis is required after 6 months of initial diagnosis. The second option is that functional MRI is the investigation of choice. Functional MRI is the investigation of choice. Yeah. The third option is that fluency improves better than the accuracy with the treatment. And the fourth option is that all the cases do not have an heritable basis. So what do you think would be the correct answer here? Let's go with each of these options first. The first option says that the reevaluation of diagnosis is required after 6 months of initial diagnosis. This is absolutely false statement. We all know that dyslexia is a persistent neurodevelopmental disorder. While we do regular assessments, which are important for tracking the progress, but a formal re-evaluation within 6 months, it's not a standard guideline, right? So option A is definitely false. The second option says that functional MRI is the investigation of choice for diagnosis. We all know that functional MRI usually is involved in research purposes to actually study the brain physiology, the brain activity in dyslexia, right? But it is not a diagnostic test of the child for the diagnosis. We all know for the diagnosis, we use a clinical diagnostic guideline, right? A clinical diagnostic criteria that is based upon a standardized reading and cognitive assessment. That's it, right? So again, this is a false statement. Option C says that fluency improves better than the accuracy with treatment, which is again false. Which is again false. Fluency, that is the speed of reading or the ease of reading, is actually more challenging to develop and it takes a longer time. Accuracy in reading improves better before than fluency, right? Fluency takes a lot more time to develop. The accuracy develops sooner. Last option is that all the cases do not have a heritable basis, which is actually true, It is seen that studies mostly show that around 60 to 80% of the cases usually have an heritable basis. And definitely environmental factors, prenatal influences, perinatal complications, they also contribute to dyslexia. but not all the cases are inherited. Though it has a strong genetic component, but not all the cases are inherited, right? So the correct option here is option D, that all the cases do not have an heritable basis, which is a true statement. Rest all the three are false, right? Moving down to the next question, we have a question regarding dyskeratosis congenita. So they're saying which of the following is not seen in dyskeratosis congenita? And the options we have are leukoplakia, nail dysplasia, skeleton malformations, and tooth abnormality. First of all, what is dyskeratosis congenita? Dyskeratosis congenita, we all know it is a very rare genetic disorder. What happens in this disorder? There is abnormal telomere maintenance, right? So because of this abnormal telomere maintenance, there is progressive bone marrow failure and also mucocutaneous involvement, mucocutaneous abnormality, CC. In dyskeratosis congenita, we see a classical triad. What is the classical triad that we see? We see oral leukoplakia that we see in approximately 80% of the cases, right? The second is the nail issue, that is the nail dysplasia, right? This dysplastic nails would be dystrophic, brittle, rigid nails, right? And the third is the skin pigmentation. This pigmentation is typical reticulated pigmentation, right? Additionally, we can also see tooth problems, tooth abnormalities like delayed eruption of tooth, hypodontia, enamel defects, right? The skeletal malformation is actually not a typical nature of dyskeratosis congenita. Some cases can have minor skeleton abnormalities, but this is actually not a defining characteristic feature of the disease, right? So the most appropriate answer here would be skeletal malformation. Rest all leukoplakia, nail dysplasia, and tooth abnormality are very well appreciated in dyskeratosis congenita, right? Now moving to the third question. So a child with the following EEG visits with your clinic. The EEG showed a typical three-heart spike and wave complex. Three-heart spike and wave complex, right? And we all know this three-heart spike to wave complex is associated with absence seizure, right? So they gave an EEG of absence seizures and they asked which of the drug is not indicated in such absence seizures. And the options we have are sodium valproate, carbamazepine, levetiracetam, and ethosuximide. We all know that carbamazepine and oxcarbazepine. The both of these drugs are contraindicated in absence seizures as well as myoclonic seizures. They can actually worsen these seizures, right? So a drug that you won't be giving here is carbamazepine. Rest all you can give, right? Carbamazepine is contraindicated here as it can worsen the seizure. They actually promote absence or myoclonic seizures, right? So the correct answer here would be straight away carbamazepine. Moving down to the next question. Liver transplant is indicated in, and the options we have are galactosemia, hereditary fructose intolerance, tyrosinemia, and Gaucher's disease, right? We all know that galactosemia and HFI, we both are primarily managed by dietary restriction, right? We don't need liver transplantation in these cases. Similarly, for Gaucher's disease, we all know it is a lysosomal storage disease and we have enzyme replacement therapies and substrate reduction therapy, which are definitely better than liver transplantation. But in tyrosinemia cases, when there is severe liver dysfunction or indocyanine is not working, then liver transplantation is definitely a curative option if done early, right? So the correct option here would be option C, that is tyrosinemia, right? Now moving down to the next question, question number 5. So we have a child with normal growth velocity and the bone age is equal to the chronological age. What would be the likely cause of short stature over here? The options we have are constitutional short stature, familial short stature, growth hormone deficiency, and chronic kidney disease, right? This is one of the questions which is a very basic questions. We all know whenever we classify this short stature, we look at the growth velocity. If the growth velocity is normal, then this is a physiological short stature, right? Whereas if the growth velocity is not normal, following a lower centile, then it is a pathological short stature, right? So the first statement is that it has a normal growth velocity. You definitely rule out these two options, which are the pathological short stature, right? Now the options we have are constitutional delay in growth and puberty and familial short stature. The second line gives it all. Born age is equal to the chronological age, right? We all know in constitutional delay of growth and puberty, my bones are growing growing slower than the age, right? So my bone age is less than the chronological age. But in familial short stature, bone age is equal to the chronological age. So the correct answer here would be familial short stature, right? Moving down to the next question. Which of the following infections, bacterial infections, mimic appendicitis in children? The options we have are Campylobacter, Yersinia, E. coli, and Salmonella, right? Again, a factual question and a very pretty straightforward question. We all know that Yersinia Yersinia enterocolitis, it mimics the acute appendicitis. Why? Because of the mesenteric adenitis, lymphadenitis, and terminal ileitis. And terminal ileitis, right? Because of the involvement of the mesenteric lymph nodes and inflammation over there and terminal ileitis, the symptoms are very similar to that of acute appendicitis. You will appreciate that there is right lower quadrant pain, fever, vomiting, diarrhea, and that leads to misdiagnosis in some cases, right? Here we can diagnose Yersinia via stool culture, blood culture, or we can also go for serology, right? In Nelson, also a very straightforward statement is given that in Yersinia, in most of the Yersinia cases, the presentation is very similar to that of acute appendicitis, and in some cases, Campylobacter also, right? But if you have to choose between Yersinia and Campylobacter, Yersinia would be a better option, right? Yersinia would be a better option. But Campylobacter is more notoriously associated with GPS, right? And not acute appendicitis like presentation. E. coli, we all know it is a common cause of diarrhea and UTI, but it does not causes mesenteric adenitis as such similar picture. Same goes for Salmonella. It causes enterocolitis and bacteremia, but usually do not present as acute appendicitis, right? Moving down to the next question. We have a child aged 2 years, 12 years, and the child has features of proximal muscle weakness. Proximal muscle weakness, right? The child has a positive Gover sign also, and the CPK is within the normal limits. What was the likely diagnosis? The options we have are SMA type 3, myotonic dystrophy, Becker's myotonic dystrophy, muscular dystrophy, that is BMD, and Nemaline Road congenital myopathy, right? We know that in DMD and BMD, CPK is definitely elevated, right? They usually have very high levels of CPK, that is due to muscle breakdown. Here in the scenario, the CPK is within normal limits. So let's rule out this first option straight away, right? What about myotonic dystrophy? Myotonic dystrophy usually presents with distal weakness and not proximal weakness. So again, rule out this option, right? The third option, Nemaline rod congenital myopathy. It is again a myopathy that presents with proximal weakness, right? It also has normal CPK levels, right? So this seems to be a more appropriate answer. What about SMA? In SMA also a similar picture is there. There's proximal muscle weakness and CPK is usually either normal or elevated, right? So we have two candidates over here, A and option D. Option A and option D. Out of option A and option D, I believe option D would be a better answer considering the age of the child, right? In SMA, hypotonia would be more pronounced, right? So this would be the better answer over here. Moving to the next question, the question gave some clinical features and they said that what is this phenomena called, what is this observation called where clinical features appear earlier in successive generation? We all understand they are talking about the observation anticipation, right? Anticipation. What happens in anticipation? Anticipation refers that there would be an earlier onset and increased severity of a genetic disorder in successive generations, right? So there is an earlier onset and increased severity in successive generations. Where do we see this anticipation phenomena? We usually see this in trinucleotide repeat disorders, right? Trinucleotide repeat disorders. Can you recall some of the trinucleotide repeat disorders? Myotonic dystrophy, Huntington's, Fragile X. In all of these trinucleotide disorders, repeat disorders, we see this anticipation phenomena, right? Moving down to the next question. The next question was a very hot favorite question of both I and I as well as NEET SS people. They ask about the criteria of cyclical vomiting syndrome. I've discussed it thoroughly in the elite test series also, in the main videos also, right? So what they say is that what is the cyclical vomiting syndrome criteria, right? So they ask about the Rome 4 criteria of the cyclical vomiting syndrome. We all know what that criteria says. That criteria says that there should be a recurrent episodes of vomiting, severe vomiting, at least 3 episodes in 6 months, with at least 2 episodes in the past 6 months, right? With at least 2 episodes in past 6 months, right? And their episodes are very stereotypical, very similar presentation in each of the episode. Regarding the duration, they can last from hours to days, right? They should a symptom-free interval in between. And lastly, there should not be any other metabolic, GI, or structural disorder that explains the symptoms, right? So they typically ask about these, and most commonly the option that they wrongly give is that there is some underlying metabolic problem or gastrointestinal problem that leads to this, right? Moving down to the next question, we have for Down syndrome. The Down syndrome is caused by, and the options we have are meiotic non-disjunction, mitotic non-disjunction, mosaicism, none of the above. Though mosaic can also cause Down syndrome, but 95% of the cases we know it is due to maternal meiotic non-disjunction, right? Failure of separations of the chromosome in the maternal side. Usually maternal meiotic non-disjunction is the cause of Down syndrome in 95% of the cases, right? Moving on to the next question, question number 11, holoprosencephaly. They're asking that holoprosencephaly is caused by, is associated with mTOR pathway, sonic hedgehog pathway, RAS MAP kinase pathway, or none of the above. Though holoprosencephaly is associated with a lot of genes, if you study through Nelson, then in the congenital abnormality section, there is a spectrum of genes given along with the different abnormalities. And in holoprosencephaly also a lot of genes are given, but it is the sonic hedgehog gene that is most commonly associated with holoprosencephaly, right? Moving to the next question, in the management of SMA, nusinersen is administered by which route? We have intravenous, oral, intramuscular, or intrathecal. We all know what is nusinersen. It is an antisense oligonucleotide, right? By exon skipping technology, it helps in reading the correct frame and production of the functional SMN protein, right? The route by which we give this is intrathecal route. Moving down to question number 13. So rapid onset clinical scenario where they gave a child with rapid onset obesity and skin picking disorder, right? Both of these things typical of Prader-Willi syndrome. If you go through the main lectures and main videos, and even if you go through Nelson, there is a beautiful table given with the major criteria and the minor criteria of Prader-Willi syndrome. And in the major criteria, there is rapid onset obesity. And in the minor criteria, there is this skin picking behavior or abnormal behavior, behavioral problems, right? So such typical presentation is commonly seen in Prader-Willi syndrome. Moving to the next question, again, a very basic question, Casal's necklace. Casal's necklace is due to the deficiency of biotin, niacin, vitamin A, or vitamin C. We all know Casal's necklace is due to niacin, that is B3 deficiency, seen in pellagra, right? Moving to the next question. So in the next question, what they gave a picture very typical of this acrodermatitis enteropathica, and they asked about which gene is involved over here, which mutation is involved over here. We all know that acrodermatitis enteropathica is a very rare autosomal recessive disorder where we see a mutation in which gene? We see mutation in SLC39A4 gene, right? This encodes a zinc transporter, a zinc transporter. The zinc transporter is responsible for the intestinal zinc absorption. And because of the mutation over here, there is failure of the intestinal zinc absorption. And we all know what are the clinical features that we see. A typical picture was given in the exam. That is, there is acral dermatitis, eczema-like rash, periorificial rash, right? Apart from that, there can be diarrhea, alopecia, growth retardation, and because of the increased predisposition to the infection, immunodeficiency like presentation would also be there. The treatment is nothing over here. We just give lifelong zinc supplementation, and that zinc supplementation leads to rapid resolution of the symptoms, right? So this covers the topics here and there, some topics over the last 3 years of the NEET SS exam. Some of these questions are from NEET SS 22, some from 23, and some for 24. I hope you got an idea of how the examiner wants to manipulate the questions. What are the type of questions they're going to ask? Remember, three type of questions you're going to face. You can't afford to mark the easy ones wrong, right? And try to get a hold of the factual questions also, because most of them are repeated questions. So as you go on solving a lot of MCQs, you're going to get a hang of those factual questions. And the tricky ones you will get again by solving MCQs, because you will try to correlate the recent guidelines and the clinical scenarios and get a hold of it. Right. So that's it for today's session. We discussed around 15 sessions, 15 questions, right? So if there is any doubt amongst these, you can drop that in the chat box, or we can end this discussion. Any doubt over here? Okay, so if there is no doubt, then we can definitely end this session. Uh, Last announcement I need to make is that we are having an all India mock test. I urge you to give that test. We have a group over here. Yeah, so we have NEET SS mock test, All India mock test, right? And that would be based upon the new pattern, that is the three time-bound sessions, A, B, and C, right? This is for all the groups, pediatric group, medical group, surgical group, and try to attempt these questions. The test is live now, so you can go ahead and attempt that and learn from your mistakes, learn from the new pattern, and definitely that would be really helpful, right? So that's it. Let's end this discussion.
Thank you, ma'am.